definition of clinical reasoning is the ability of you, the clinician, to sort through a cluster of information that presented by a patient and accurately assign a diagnostic label with the development of an appropriate treatment strategy as the end goal. So what this means in a nutshell is really for you to be able to put together the chief complaint, take a good history, perform a physical exam, order diagnostics if needed or labs, and come up with a diagnosis and treatment options. Diagnostic reasoning is an important component of the clinical expertise of a nurse practitioner. So the goals for nurse practitioners in providing primary care include diagnosing and treating the disease itself, but also treating the patient's responses to illnesses. So your job is to diagnose and treat the illness and also monitor patients for their responses. So was a treatment effective? Did the patient get better or not? Do you need to order more tests or do you need to refer this patient out? So you have to make this decision in order for you to be a good diagnostician. These are some questions to ponder. So what is the leading diagnosis? And of course, for you to ask this question, you should know your pathophysiology based on the presenting symptoms. You want to know the top 3 to 5 differential diagnoses. Why do you think that's correct? And why does your diagnosis fit? So these are questions to ponder while you're thinking about the case in front of you of a patient in clinical practice. With clinical reasoning, clinicians build on their prior knowledge. So you want to think about other patients that you've seen like this before and what you've been taught or what you've learned in the past before about this case scenario. We typically use a stepwise approach to identify the chief complaint, which is subjective findings, review of patient's general health, again, review subjective findings, then performing physical exam, which is objective findings, and then lab diagnostic tests and differential diagnosis. The algorithm here tells you how to sort through the history and hopefully you can make sense of it. So you want to allow the patient to describe their presenting symptoms, and then you want to consider 3 or more hypotheses. You want to consider the patient's presenting symptoms and their basic demographics, so their age, gender, their ethnicity, their socioeconomic factor, and even their level of education. What are the key features of each of these hypotheses? What are the distinguishing features of this hypothesis? So I want to give you an example here. So for a patient that has, let's say, hypertension and is African American, you ought to know the epidemiology of this disease process, that it's more prevalent in African American males or African Americans in general than in other ethnicities. So that gives you a basis for your hypothesis. And then you want to continue with your history taking. So explain why each question was asked related to the hypothesis. And then does the new data help or hinder your hypothesis? You want to be able to reprioritize the hypothesis with each new piece of information you gather. and then refine the diagnosis. You want a primary hypothesis and a differential diagnosis. So, of course, you want to be able to perform a physical examination, consider what findings are expected given the hypothesis, and look for them. And then discuss relevant positives and negatives. And this could be refined with the hypothesis that you have right in front of you. And then, of course, the relevant investigation. You want to consider the diagnostic testing. This may be required for you to be able to rule in or rule out a diagnosis. And then ask yourself this question: will the investigation confirm or alter your hypothesis? If not, is it necessary? So that test that you want to order or that MRI that you want to order, would that help you to make a better decision, or would that even affect your course of treatment in the first place? So I'm going to talk about the process here in a little more detail. So for your chief complaint, you want to identify your chief complaint and determine what the patient is saying. Clinicians should be able to ask a series of open-minded questions and create a general history of the symptoms. And then the symptom analysis questions will help establish the onset. So you want to ask the patient, when did this symptom start? The location, where does it hurt? And you should be able to describe this effectively. Duration, how long has this been going on? The character, is it worse or is it getting better? Is there any associated symptoms? Is there any triggers? Any alleviating factors? Or does it impact your daily life? So clinicians should ask directed questions that could clarify or provide additional information to help you narrow your diagnostic possibilities. For your review of systems, you want to be able to gather or confirm the general health information that you're asking the patient. Clinicians should be able to uncover new facts that could lead to a diagnosis. Clinicians should review past medical history, familiar history, so any family history, any social history to determine the disease risks or risk factors, occupational exposure. Is there any use of harmful substances or presence of drug or alcohol use or abuse? For your physical exam, you want to perform a thorough physical exam. Most of the time, you're going to be performing a focused physical exam that is directed to the patient's chief complaint. Keep in mind that if the patient is there for a well exam, then you're performing a head-to-toe exam. Clinicians should be able to take into account the patient's physical expressions. Check the patient's mood. Are they angry? Are they happy? Are they stable? Patient's hygiene, stress level, their skin color or condition, and their breathing patterns. And this may give you information that is vital for you to make a good diagnosis.
Beta!
And then for your assessment, you want to be able to determine what assessment testing that you may consider ordering to be able to help you make the correct diagnosis. So you start with a process of basic testing and continue to advanced testing if this is needed. And of course, the question is, the additional testing that I perform, will that help me make a good diagnosis and treatment option? So for your plan, keep an open mind to all possibilities. Think about the zebras, and the zebras are your outliers, and these are the worst possible outcome. Always think about those. Remember that premature decisions may result in a diagnostic error. Treatment plans can include your pharmacological agents, patient education, and follow-ups. So in determining your likely diagnosis, it's important to keep an open mind at all times. You also want to be able to list your differentials. You want to rule in or rule out based on your knowledge of your pathophysiology or health assessment that you performed. You want to be able to demonstrate why this is accurate for the case. And keep an open mind about other possibilities. I talked about zebras. And if this patient needs to go to someone else or maybe a specialist, you should be able to make this decision at this point. So we'll switch gears and talk about diagnostic errors. So with faulty hypothesis, the clinician either fails to consider the initial hypothesis or fails to revise hypothesis to reflect new information. With faulty context formation, the clinician has competing goals for a patient encounter. For instance, when you have a patient that is here to see you for health promotion, but also needs to see you for an acute visit. So you want to be able to tell the patient that you can address one visit, one information per visit. So she can come in for a well visit and then come in for her acute visit the next time around. So with faulty history taking, this occurs when the clinician either fails to order the appropriate tests or misinterprets the tests or the test results. And then with faulty diagnosis verification, this occurs when the clinician fails to collect enough evidence to confirm the diagnosis or to rule out a competing diagnosis. So I'm just going to go ahead and discuss a case study here. So we have a 13-year-old female that reports to the clinic with complaints of right shoulder pain that hurts and burns all the time. The history of presenting illness. So patient tells you that in May, she was pitching in a softball game, and as her arm circled back and down to throw a pitch, she felt a pop and a pull, and then she had some burning in her shoulder that radiated up to her neck and down into her right upper arm and to her elbow. Patient was unable to finish the game. She was seen in the ED and had a sling applied. Her past medical history, so she has a history of asthma. She had a tonsillectomy in 2013. Her social history is unremarkable. No tobacco, alcohol, or recreational drug use. For allergies, patient has allergic reactions to Bactrim, penicillin, and Toradol. She's currently on ibuprofen 600 milligram every 6 to 8 hours for pain. So review of systems, constitutional symptoms, no weakness, no fatigue, fever, or night sweats. The eyes is unremarkable. The ears, nose, and throat, unremarkable. The neck, she has no lumps or swollen glands, no pain or neck stiffness. For respiratory, she has no reported shortness of breath, no heaviness, or difficulty breathing. Patient has no chest pain, and her GU is unremarkable. Her GI is unremarkable. For musculoskeletal, you can see that she has right shoulder pain and slight swelling, no joint stiffness or muscle pain, and skin is unremarkable. For neuro assessment, she has no headaches, no focal weakness, no numbness, no tremors, and no memory decline. Hemi and lymph, no easy breathing, and with psych, patient is age appropriate and patient is very pleasant. So I want for you to also consider that at this point, the history and also the review of systems is all subjective data. So this is what the patient tells you. So keep that in mind. So we'll talk a little bit about the physical examination. So you start with the vital signs. Blood pressure is 108 on 64, heart rate is 60, respiratory rate is 18, SpO2 is 100%, and patient's pain level is 8 out of 10, and I think that's pretty significant. So, of course, the patient is a 13-year-old female, and she's accompanied by mom and dad. She's alert and cooperative. So this is where you come in. This is your assessment. So chest is clear, no wheezes, heart rate is regular, no abnormalities. And with the right arm, you looked at it, no cyanosis, no edema, no ecchymosis. She has some discomfort. So you continue with your physical assessment. You found no joint deformities in the hands and no erythema. But patient has some slight edema to the right shoulder and also her upper back. And she also has some discomfort on light palpation, which is increased when you deeply palpate the trapped muscles. But no impingement was noted. Your neuro assessment showed no numbness or tingling, but she has some slight burning through the right posterior shoulder and burning pain with range of motion of a shoulder and the upper right arm. So with your assessment, you think about your hypothesis and your list of differentials, and what we have here is shoulder dislocation, trapped muscle strain, thoracic outlet syndrome, peripheral nerve injury, suprascapular nerve injury, and rotator cuff injury. And the diagnosis is right shoulder pain with possible suprascapular nerve injury. And the reason why suprascapular nerve injury is the diagnosis is because this happens when there is an irritation and damage to the suprascapular nerve. The patient complains of weakness and burning, just like your patient complained about. The irritation in the suprascapular nerve is what causes the symptoms. So the patient may have some shoulder or arm weakness or heaviness. They may have some radiating or burning pain to the neck, back, or arm. The pain is worsened with shoulder movement, and you noticed that when you were assessing this patient. There may be some loss of shoulder function, some atrophy, or some discomfort in the shoulder and the upper back. So the plan is to ice and heat and alternate that for discomfort, Tylenol with codeine for severe discomfort. The patient rated pain out of 10, and they can use the sling sparingly. Teach them about range of motion exercises as patient tolerates. And a referral to imaging is necessary in this case. So basically, you may want to also consider physical therapy and have the patient come back in a week for follow-up for the MRI review. And you may want to eventually send this patient to a referral to an orthopedic specialist.